Good morning, everyone, and welcome. And really appreciate your participation on this special event that we're running through VADA to just give the sector a briefing on what's happening with the mental health reforms in Victoria. Before I begin, I'd like to acknowledge the country on which we're on and begin by acknowledging the traditional custodians of the land on which we meet today and pay my respect to their elders past and present and emerging. And I'd also like to recognise people with lived and living experience of trauma, neurodiversity, mental health challenges, psychological distress, suicide, substance use or addiction, and their families, carers, supporters, and those experiencing bereavement, advocates and allies. I'd now like to introduce you to Gillian Clark, who's our Special Projects Officer at VADA, who's focusing exclusively on the mental health reform space for us. I'll hand it over to Julia and she'll introduce the way in which the proceedings will go today. Julia and Gillian, I'm not sure if Julia's going to do an overview first or Gillian will do the overview first, so one of you will.
I'll start with some technical housekeeping. So for those of you who are unfamiliar with Zoom, we are joining in a webinar format today. There will be two ways through which you can ask questions. The first is using the Q&A function, which looks like two chat boxes at the bottom of your screen. The second option is through raising your hand to request to be unmuted to ask the question verbally. Beyond there, the chat will only be monitored for technical queries and comments. This webinar is being recorded and we will save a log of the Q&A and chat for our own references. During the Q&A times, which there will be two of, we will pause the recording. So any questions asked during those Q&A times will be asked in confidence to this group. Beyond there, any other technical questions, feel free to field them in the chat. I'll pass things over to Gillian to start things off.
Thank you very much, Julia. And I just will mention towards the end of our session today, there will be an opportunity for you to unmute and speak. Julia will be in control of that. But for the most of the time, as Julia said, it will be via the Q&A function. Thank you for the welcome. I'm really glad to see so many people are interested in this topic, and going forward, I think certainly on VADA's behalf, on behalf of the sector and behalf of the people that we try and support, a lot of changes will happen, and it's really an opportunity to position ourselves well for the future and to think about where our sector can sit going forward and how we can strengthen our position. So I'm going to share my screen for some slides. Oh, if Julia can allow me to do that, that would be good. Oh, here we go. So a bit of background about why we're here today, and some of you may know more of this than others. I guess I will start with a caveat too, is that this is, information that we've gathered through the early process of the Mental Health Royal Commission findings. Throughout this morning, we'll sort of put a lens on it through an AOD perspective, but I guess I certainly don't know everything going on, and there's lots of questions that we don't yet have answers for, but we'll do our best to try and fill that void for people. So as we know, the Royal Commission was established after the Victorian government realised, after a long time, I think, of complaints and concerns from people accessing the sector and for those working in it, that the system just wasn't working, and there was, I guess, broad scoping needs to improve how things were made, how things were run. 65 recommendations were made overall, and there was bipartisan support for the implementation of all these recommendations over a 10-year period. So we've got a long change process ahead of us, and as some of you may be aware more than others, the pace at which things are moving is quite quick for lots of different reasons. And some of that is challenging, I guess, the idea of when timelines were established by the Royal Commission initially and sort of what's happening on the ground in light of so many other factors that we're all well aware of, including the pandemic, but workforce shortages, changes within our sector, and I guess, yeah, the implications of the work that we do and the struggles that we have around that. So it is important to highlight that the AOD sector wasn't in scope for review in the Mental Health Royal Commission. So they had terms of reference that highlighted what they were to be looking at, and it was made quite clear that our sector was not going to be reviewed. However, it's really evident that because our systems, mental health and AOD, work closely together, because the people we support do have co-occurring mental health and AOD issues, the impact is inevitable in terms of how the change in the mental health sector will affect what we do, how we do it, and the people that we support. Really also important to acknowledge that the Royal Commission itself highlighted some of the many strengths of our sector. And I think, as we've certainly seen in VADA going forward, working in the integrated treatment space, it's really clear to us that some of these foundations of our sector, like putting consumers at the heart of decision making, our peer workforce, the biopsychosocial model of care that we offer, and that non-judgmental perspective, are key elements that the mental health sector need to develop in order to be able to meet the vision of the Royal Commission. That quote at the bottom just highlighting that you know, it was stated in the Royal Commission that the intention is to ensure that the strengths of our AOD system are retained, including within individual services, and that integration should not come at the expense of the model of care that our sector has developed over many years. I think these points are really important as we move forward, and certainly in a platform of advocacy for our sector, to remind us that our sector is valuable and does fantastic work on its own, and needs to retain that strength going forward to be able to support any work that the mental health sector does. So what are we seeing in this space so far, I guess, and what's our position? So I've been in this role since December last year. And, you know, as I said, it's been a fast-paced flurry of work, lots of things happening in different spaces. I think overall, the feedback that we've, you know, heard from you, from our sector members, but also in, you know, within VADA, is that we're supportive of the recommendations. We're supportive of changes that have been suggested to the mental health system. We intend to support that process from beginning to end and review and continue to be involved in that process. But we also need to heavily retain a focus on ensuring our funding support and strategic planning is ongoing, is I guess, commensurate to the mental health sector, and allows us to continue our strong foundations whilst the mental health system's changing and into the future. So that leaves us a couple of questions, I guess, about how can we mentor, or what's our sector's role in being able to support these changes in the AOD sector. And whilst I say that from a VADA perspective, I think that's certainly, you know, our advocacy with the department and with the Mental Health Royal Commission key decision makers about how we retain our strength, but also the strength that we have being able to be imparted across the road to the mental health sector, but also at an individual level, you know, on the ground. How can we do that? How can we do that at a service to service level and through partnerships, supports? The other side of that coin is, what do we need? What does our sector need in order to support systems change? And how do we need to adapt, or how do we need to support our sector to manage this change process? And I think our sector, better than others, some others are unfortunately used to change. We all know that 2014, during the recommissioning, was a huge, I guess, issue within our sector that continues to have ramifications, continues to be present in the way that we work with one another and work cross-sectorally, and I think also have confidence in the work that we do. So I think it's really important that we come together as a sector to support and identify what supports that we'll need in order to do that work going forward. So the last line there is just, I guess, our sort of lens on this, keeping in mind that it's such a long 10-year process, is about listening, learning, informing, collaborating, advocating, reflecting, and doing, like continuing to do the work that we're all doing. So I'm going to go through some of the key recommendations. As I said, there were 65. I'm not going to go through all of them. Some of them, as we've gone through, are far more relatable to our sector than others. So some of them directly impact the work that we are going to do going forward. Some of them have an indirect view, and some of them will impact on the people that we support. And obviously that will then come through in the services that we provide. So the first recommendation there is the establishment of the 60 mental health and wellbeing services across Victoria, the locals as they're being called. Oh, that didn't do what I wanted it to do. So eventually there'll be 60 of these local mental health and wellbeing services across the state. As you can see by this slide, it's a phased out operation. And we actually are waiting for imminent notification of who will be the first 3 successful tenders right now. Apparently it was due for delivery on the 31st of the month, but of May, sorry, but we're yet to hear. So the first 3, Benalla, Latrobe Valley and Frankston, then another 3 that will be operational by December. And then following that, towards the end of the year, I believe they've sort of slated it for between October and December, they will put out new tenders, applications for another 21 areas that are listed there below. So the basic idea behind the local services is that they are a one-stop shop for people with mental health and wellbeing issues. It's a front door. It's looking at the low to moderate needs, although that's an area that's still waiting to be defined, but not acute, I guess, is it? It's in addition to the acute mental health system that's existed for many years. All of the local mental health and wellbeing services have quite an extensive tender application that they have to go through. And one of the main features of the work that they have to do is that it will be integrated. So mental health and AOD, integrated treatment, care and support. So all these services in the tender application have been, as well as the area services, I should note, have been advised that they need to develop an integrated model of care, either through co-location, service partnership, or through a multidisciplinary team environment. Obviously, all of those 3 ways of working will require AOD expertise and workforce. So some of you in the room today may be aware that your services or you have been partners in tendering applications to date, may have been approached to consider partnership. And, you know, I guess particularly as we begin to wait for announcements of the successes as we go forward, this is something that will significantly change the way that we work. So, for example, if one of our AOD services is a successful applicant or partner in a tender, they will then be providing services through the local mental health and wellbeing services alongside what they already provide as part of being an AOD service. Significant growth, and I guess some of our key concerns about this going forward are the idea of workforce, where are all these people coming from to be able to work, and the dissemination of our current workforce by people transitioning over to these new services. But then on a broader scale, I guess this is obviously mental health funding. It's a mental health service funded under that umbrella. And we want to be able to support anyone working in the AOD space, obviously, but it creates almost a separate workforce of people that are potentially mental health and AOD clinicians in one, depending on the model of care. So important to have be aware of where the locals are coming and what are the ones that might be in your catchment area. And when you hear who's been successful, being able to contact them. So the next area is that one of the recommendations was significant changes in the area of mental health and wellbeing services across the state. And whilst many of the changes will take 10 years or more to implement, the area mental health services were all given what's called transformation plan to complete for the Department of Health to indicate how they intend to implement these 8 priority areas for transformation. There's actually quite a lot of work if you go through these 8 areas in how they would have to adapt and the resources that they would require to be able to adapt. So it's a big piece of work. Just to highlight a couple of these particular priority areas, number 2 there is about having a division between what they call infant, child and youth mental health services and the adult and older adult stream. So they already exist, but there's a blurred line, and the models of care are often not developmentally appropriate. Expanding more core clinical services, those that have worked closely with area mental health services understand that it's largely a medical model. This is highlighted in the Royal Commission report itself through people, I guess, seeking mental health treatment and support for a range of conditions, but finding that their needs are not adequately met within this system. And yet it's the system that receives the bulk load of funding to be able to support these people, particularly with acute needs. So the idea is that they'll expand that to be a little bit more, hopefully, biopsychosocial in nature, and using, again, those different models of care. Again, will require AOD workforce in order to do this. The other, number 5 there, is important for our sector. So eventually the area mental health and wellbeing services will have to provide primary and secondary consultation to other systems outside of their own, and it includes the AOD sector. This is quite exciting and something that we're well required to be able to support those that we need, that we work with, particularly those that present in crisis or are struggling with what's going on in their life at any given time, that we can actually call on primary and secondary consultation in a mental health space rather than actually having to refer and then being told that they're not suitable. Number 6 is also significant, and some of you may be involved in this, or your organisations may be involved in this, because all the services, area services, have to partner with a non-government organisation, which will partly enhance their ability to expand their core clinical services, but also provide a different level of governance. And then number 7, which we'll touch on a bit later, is around the integrated care information. Regional boards, this is who your regional board chairs have been announced. So the idea behind the regional boards is similar, I guess, in some way to the PHN model that operates across the country, with the idea that eventually these regional boards will be able to do needs identification and commissioning and service planning in individual catchments, which, I'm from a regional area, and, certainly that's most welcome from my perspective, to be able to give that specific regional viewpoint. Again, these are the board chairs, these are the people that have been appointed. There's recruitment that is closed for other board members, but their actual service won't commence until towards the end of the year. And as you'll know, it says interim regional board chairs. So the regional boards are also connected to the Mental Health Act legislation and the setting up of the commission, the Mental Health Commission. So until that act is formally passed, their powers will be limited, I guess. The Statewide Centre and Addiction Specialists, this area I think is something that our sector is particularly interested in. We're excited that Turning Point has been appointed as the lead agency, so an AOD service provider. I guess at this point in time, it's really early days. We know that the Statewide Centre is in the process of developing a service and capital plan that will have to be shared with the department and then enacted on. We've been advised that there will be significant consultation between now and the end of year when they have to be operational in terms of their model of care. I think a key concern for us is that at this stage, and probably with rationale based that it was a Mental Health Royal Commission, not an AOD one, but they have been advised that their key focus will be on the area mental health services. And certainly the role of primary and secondary consultation that the addiction services are to provide is to be for area mental health services as a starting point, with the idea that we may get access to that in a few years' time. So again, any of you that work in hospital settings may be aware that expressions of interest tenders have been open for these addiction services. They're now being reviewed by the department, and we've been advised will be announced sort of July. The idea as outlined there is that these addiction services will be a support to mental health services, look at working together with the statewide service to provide education and training, and coordinate access to addiction services where required from that mental health lens. We've also been advised that another 8 addiction services will be established as time goes on, and there was funding in the recent budget around that. The lived and living experience workforce. So as some of you may be aware, the Royal Commission was really strong on the need to shift our focus away from, I guess, service-led models of care to person-centred led models of care, and the idea of involving lived and living experience families and supporters in that work. So there's, across all of the recommendations, really, there's work that's gone into or is going into involving lived and living experience. And these are just a few of the areas that have been highlighted. So some of you may be aware, Mary O'Hagan has been appointed as the Executive Director of Lived Experience as part of the Mental Health and Wellbeing Division, the first of its kind. There's also teams within the department, both in mental health and AOD, of lived and living experience workforce. I think also key to this from that leadership perspective is that all the Commission, the regional boards and the area mental health services all have to consider, they have to have members with lived experience in leadership roles. From a service delivery perspective, hopefully some of you may have seen come through e-news the other day that Shark and VMIAC have announced the establishment of the Our Agency service, which is, as it said, an agency for us, for the people that access services to support the development of the lived and living experience workforce system, I guess. The other significant piece of work from the Royal Commission is about the design and delivery of a residential mental health program by lived and living experience people. So there's been ongoing discussions about that for some time since the Royal Commission was announced, but we're yet to hear any more details. We also know that there's going to be a significant expansion of lived and living experience workforce, and our partners at Shark, VMIAC, Tandem, HRVIC have been involved in a lot of work in that space to try and identify what the workforce is, to try and get some solid foundations for what that workforce will require in order to develop and grow. You may have seen a survey that's been out recently to that effect. And I guess just on that note, being one of the areas that VADA are interested in is making sure that the demographics of our workforce, including those in professional roles that have a lived and lived experience, are also captured with the intent of being able to inform, you know, how they got there, why they do what they do, and how that might influence and support the workforce going forward. Co-design is a bit of a buzzword in the Mental Health Royal Commission, and I wish I could sit here saying that it's well understood and well practiced. At this stage, what our experience has been is that whilst the intention for co-design is often there, the difficulties with timelines and pressures for delivery mean that it's not probably as robust as it could be. And there's some real risks about that going forward in terms of, I guess, any work that's pushed through actually not properly reflecting what those experiencing service actually want and what will fit at a service level delivery sort of perspective. Here's a whole lot of other recommendations. I'm not going to go through them all, but I guess if people have questions, that's why we have the Q&A function. Probably the last one I will just mention around funding reform. So we have been advised that there is currently some AOD demand modelling work going on through the system architecture branch of the Mental Health and Wellbeing Division. And we're yet to fully understand the basis of that, what they're actually looking at, and how that relates to future funding for our sector, but also in conjunction with the mental health sector. But we're certainly asking lots of questions in that space, and very aware that probably an important reflection to understand is that, you know, these are only some of the recommendations, but the amount of consecutive work that's going on in the department at the moment is significant. And what we've observed is that, unfortunately, the crossover between some of those pieces of work isn't great. And the consequence of that is that we might find that some pieces of work don't fit with other pieces of work as they start to be implemented. The funding reform is a big, I guess, piece of that, because once the foundations are set for how we actually deliver service and who gets funding to be able to deliver what service, what the system design looks like will heavily impact on the work that we do going forward. So unless there's any last burning questions, I think we might go to a 10-minute break and then come back and hear a little bit more about integrated treatment. In that time, whilst you're away having your break, do you think of any more questions? And you can add them to the Q&A or the chat when we come back. So the time is 12:02, so let's come back at 12:12. We'll see you shortly. Welcome back, everybody. I hope you had a nice stretch and time to grab a cup. Oh, that's probably good to start my video so I can see you, or you can see me. So we're going to spend the next bit of time having a look specifically at the integrated treatment, care and support guidance, the ideas behind that piece of work. And as some of you may have heard me say before, VADA was funded initially to, I guess, work on the integrated treatment guidance. Certainly in the early days of that agreement, the idea was for us to lead that work, and that shifted over time, both due to the idea that it needs to be cross-sector work and led cross-sectorally. So as part of that work, we have developed and continuing to develop, you know, growing strong relationships with the mental health peaks, so Mental Health Victoria, Tandem, VMIAC, and to try and support, I guess, the integrated treatment idea concept going forward, but also just to strengthen our relationship with the idea that, you know, the future is that we'll be working alongside each other a lot more closely. So I'm going to share my screen again. So as part of the integrated treatment care and support guidance, as it's now being called, it's been a long process of, I guess, drafting up this document that's intended to provide some high-level advice on what integrated treatment care and support means, how it's, I guess, envisioned in operating across mental health and AOD sectors, and what enablers, supports, resources are required in order to do that. They're currently busily coming up with the final copy of the draft guidance within their department, but the last round of consultations around that was both run through some targeted consultations that the department ran, requests from certain groups to provide detailed feedback on what had been written to date, as well as a cross-sector survey that was both developed with our partners in mental health, the peaks in mental health and the department. Going back to my earlier comment about the nature of co-design, and I'm sure some of you in the room may have even participated in co-design training since the Royal Commission was released, or if not before. And I think as a first pass, or as a first attempt at doing co-design, it's really highlighted to VADA, and certainly we've shared this with our sector partners and the department, that good co-design delivery and I guess evaluation really needs time and relationship building in order to be successful. So whilst this survey captured some really important information for us, and I think is going to help us support our sector going forward, we also know that it highlighted the differences in the type of information that different partners want and the purpose of that information. So I guess the division between needing advice and consultation about a piece of work versus advice and consultation about how a sector operates, functions, and the, I guess, tools and resources we need to be able to do that properly. So just a little bit of context to that. What's on the screen at the moment is just a bit of a snapshot of data, and I'm not going to go through all of it, but I think thank you to anybody in the room that did respond to the survey. It was most generous. It was a long survey. We're very aware of that. But as I said, we got some great feedback. So appreciate it. Good to see that it wasn't AOD heavy in responses. I guess up until this point, some of the feedback we were giving was that the AOD sector were really invested in this integrated treatment piece of work. We weren't necessarily getting the same engagement from the mental health sector, which was a problem in itself. Particularly as is reflected in some of these statistics, the simple fact that our sector seems to be more willing, able and ready to do integrated treatment compared to our mental health colleagues. So we also had quite an interest from other health professionals, and one of the questions that's come up multiple times when we're looking at this integrated treatment idea is about how all the other sectors that work closely and around mental health and AOD will be impacted by integrated treatment, how perhaps some of their understandings and ways of working will also have to change in order to support integrated treatment. And certainly it's something we've raised with the department. I think going forward, something we continue to need to speak about, and certainly keen to hear your opinions on. And we did, from those other sectors within the survey, hear about their concerns going forward and how all sectors will be able to work in that kind of wraparound model of care, which is really, what the research suggests is ideal. I think just overall, you can see by looking through some of those figures that our sector, as I said, is more ready, willing and able. We've got greater confidence in being able to meet those expectations outlined in the guidance. One of the key features of setting up the integrated treatment guidance was about what I've called principled care, but it's actually looking at what are the key principles for delivery of services across AOD and mental health services, and what are the expectations associated with those principles in terms of service delivery. And these were principles that were informed by both those with lived and living experience, carers and supporters, as well as people in the service delivery space. So again, it highlights what the Royal Commission identified very early on in the piece, that a lot of our sector's, I guess, philosophy and ways of working around being person-centred, around being non-judgmental, about working holistically, are all reflected in our organisational principles. So looking at things like inclusion, looking at things like access. One section of the survey looks particularly at addiction medicine, and this was in part due to the addiction services being established and identifying need around that, but also, I guess, in reflection of the disparity in addiction medicine specialist services being available across the state. So we know some hospitals that have area mental health services have addiction medicine specialists. Many do not, and particularly the further you get out away from metropolitan services, the less likely you are to see them. I think what's really interesting, and whilst, you know, that we don't necessarily need addiction medicine specialists in all of our AOD services, the fact that our sector, our addiction sector, specialist sector, still has room for growth in terms of addiction medicine is quite important when they're considering how addiction medicine specialists could resource the new mental health system going forward. We certainly know that there is a limited pool of addiction medicine specialists in the state. We know that that's, in comparison to other states, particularly low. We know that part of the statewide service remit is to support expansion of the addiction medicine workforce. But from an AOD sector perspective, I think we really need to highlight the fact that we need to retain some addiction medicine specialisation within our own sector, along with boosting up the mental health side of that coin as well. We also know that addiction medicine is probably has a lot of different branches, if you like. So we know that it's in psychiatry, we know it's in medicine, we know it's in the nurse practitioner world, we know that there's others out there that are practicing or providing pharmacotherapy, for example, which perhaps don't consider themselves addiction medicine specialists, but could have scope to take that role on. So it's just really interesting, I think, going forward, thinking about that notion of addiction medicine, thinking about how it relates to our sector and what our sector needs in terms of addiction medicine input, what areas of the service require that. It goes back to Kevin's earlier question about where DACAS fits into that picture as well, because obviously a lot of our withdrawal nurses, particularly home-based withdrawal nurses and other clinicians, will contact DACAS for secondary consultation. And often that's their only line of addiction medicine support. So thinking about going forward how that will impact our sector. Another big area of confusion and contention within the guidance is around a notion of, I guess, who does what. So what part of what sector, what service will work with what cohort of clients. So the language that they've used in the last guidance document was low, moderate, high intensity needs, which, as we've pointed out to the department, is new language, different language than what we're used to hearing within our sector. And of most concern, it is yet to have a definition associated with it. So we're yet to understand what these different cohorts of need represent and how that actually relates to both co-occurring needs together and individual mental health and AOD needs as well. I guess the concern is how a notion of who does what is actually not person-centered to begin with. It's not kind of connected to a no wrong door philosophy, and it certainly isn't, welcoming if the first thing that is considered when you come into a service is whether you are at the right place. We need to try and shift that and change the narrative to be more about how do we help people and support people where they're at, and I guess support them to work through and funnel through the system to achieve their needs. So it's I think what was really important that came out of the survey is, that bipartisan support across AOD and mental health, that we really need to know what low, moderate, high needs means, and we need to have a clear specification around how we navigate the needs of individuals through a system that's based on acuity going forward. Of real concern is some of the locals, as I said earlier, are about to be announced any day soon and operational by October. Those services, it's been indicated that they're to work with that low, moderate intensity need cohort, yet without a definition of what that really looks like, and without, at this stage, any sort of idea about how people will transition to between the locals, the areas, the AOD standalone service, based on their need and their choice. Because we also know that some people with co-occurring mental health and AOD needs will actually choose and not be ready to address one aspect of their concern or the things that challenge them. And we need to also have a system that is able to respond to that accordingly, rather than making it our goals for their needs. And that relates to that idea of continuity of care, and a reflection that our sector does continuity of care better, and certainly has better systems in place to be able to do that, which I think just largely reflects our biopsychosocial nature of the work that we do. And we all know, everybody listening today, that we do tend to try and channel people accordingly to what they need, and we'll do that wraparound care without question. It's just part of the way that we work. The other area of principled care that was looked at in the survey is around capability, and certainly this really points to that idea about what is the workforce that our sector needs going forward, what is the workforce that the mental health sector needs going forward, and what do they need to understand in order to provide integrated treatment, care and support. Without going into too much detail, as you can see, these two slides just sort of indicating the differential confidence ratings in harm reduction and with knowledge of the other sector. With some of this tells us what we, I guess, expected to hear, in that, obviously the AOD sector has a greater understanding of harm reduction, although we always have room for improvement in that, particularly I think in certain pockets of the way of service delivery, and being able to constantly work from a harm reduction platform, or have that understanding in the work that we do. We have a potential real role to share our knowledge, skill and confidence with the mental health sector around harm reduction, and I think need to think forward about how we can position ourselves to be the leaders in that information provision. I think there's lots of work that's been done over many years. I'm sure many of you have been to dual diagnosis training over many years and trying to understand each other's sectors. Clearly, there's still room for us to understand that better, which is not helped by the fact that the sectors keep changing. So we've got to keep learning more and learning new and different things. These two graphs, I guess, really point to the idea about stigma, judgment, and service access. And I think, unfortunately, unsurprisingly, what we're still seeing is that the idea of people continuing to choose to use substances or not being ready to change their substance use can be a barrier to mental health service access. Lots of, I guess, work has been done in incorporating this idea of no wrong door and, you know, co-occurring needs being an expectation in service delivery models within the mental health system. However, without cultural and attitudinal change amongst workforce, it's really difficult to, I guess, realise that on the ground, to actually have services that are able to be responsive to people with co-occurring substance and mental health use issues that are not ready to change or choose not to change. I think that this is, again, an area that our sector has the potential to really support the mental health sector in and strengthen their response. However, it also raises an issue, I think, of workforce in this area, and the idea that will it be that mental health services need to have AOD workers within their service in order to change this culture and attitude? And if that's the case, where does that leave our sector in terms of having workers on the ground? In flipping the coin around, the bottom graph just looking at experiencing mental illness as a reason for exclusion of care, I think, and oddly concerning that the mental health system is indicating that sometimes that's you know, a reason why they may not work with somebody. And I think from my experience in working in mental health systems, it really is about this idea of compliance with treatment. It really is a medical model of care lens, and it's definitely not playing into that person-centered idea of accepting people where they're at and being able to support them where in the needs that they identify, rather than, again, the needs that we project onto them. The last two graphs here are looking at families and supporters. And for anybody in the webinar today that works in the family and carer space, we know that it's an area that needs further resourcing and further support with an AOD lens. I think these graphs both highlight that point, and it's obviously cross-sectorial as well. Interestingly, you know, mental health services have probably had better resourcing from a family carer, consultancy, peer worker kind of funding model than the AOD sector has had. And whilst we have some fantastic services that do brilliant work in this space, they're not usually continued funding, and it's definitely not across the state. So there's no equity in being able to access that at a local level service access point. So I think that this can, you know, really be a good benchmark for how we need to grow in involving families and supporters in both the care of their loved one or in addressing their own needs, with the caveat there that obviously for some individuals, families and supporters are not around, they choose not to have them involved. And I think in our sector, we need to, you know, particularly be sensitive to that and think about how we can support the needs of families and supporters in their own right, not just in relation to the having the needs of their loved one met. There was quite a significant amount of qualitative data that came out through the survey, and whilst we're continuing to trawl through all that, which is brilliant, these are some key themes that have come up, and this points to that earlier idea that I think Joe raised about, you know, tools and resources that are shared amongst the sectors, amongst other things, to ensure that integrated treatment actually works on the ground. And interestingly, however, it wasn't just the tools and the resources, it was also about the way that we work. And one of the top point there about having enough time to work with people with co-occurring needs was quite prevalent across a couple of questions in the survey. I think that's really telling about our funding models, activity-based funding, having so many sessions to work with somebody that's predetermined rather than being able to do it in a cumulative fashion. We know some services are able to have better flexibility in the way that they work compared to others, but really I think if we don't have enough time to work with the people that are presenting to us, it really doesn't allow for good treatment at all, let alone good integrated care and support. So really, I guess for us, being able to highlight some of the deficits in those funding mechanisms to be able to support integrated treatment going forward. We touched on primary and secondary consultation access earlier through the area mental health services. So that was definitely a need that was identified. More resources for care coordination and improve continuity of care between systems and structures, which again will change based on new systems stepping up and new models of care being established. Being able to have, I guess, resources and time to develop and improve cross-sector relationships. I think it will be interesting going forward, again, for many of you in the webinar today, thinking about the new relationships you may have to develop as a result of sector partnerships and consortia that are put together to achieve new tenders that come out, meet new tender obligations. So naturally, I think we'll be in a position to have those relationships strengthened, but also then, I guess, having the time outside of our clinical work to participate in that relationship development, whether that be through shared training, whether that be through regional development, or, the direct clinical work. Stigma and discrimination is still a huge significant issue, both for the people that we support, but also within workforces. I think the next point there about the lived and living experience workforce enhancement is also going to be particularly poignant when it comes to stigma and discrimination in terms of how they're accepted within services, how ready services are to be able to work with them and retain them, how we support that workforce to do the best job that they can do in the roles that they're provided, and understand that, see them as their own professional entity. There were specific questions around residential services, both AOD and mental health residential services, but specifically for our sector, looking at how we enhance funding to AOD resi services to have mental health clinicians on site to be able to better support those with mental health conditions accessing resi services. We know is a constant struggle. Issues around funding equity, and of course workforce being the last one there, that is across so many different avenues of this piece of work. So we need them to be available, we need to have access to them, we need them to be capable, and we need them to be sustained and have a career pathway that is able to keep them in our sector and pay them what they need in order to keep them here. So that's enough of me talking for the moment. This is a snapshot of what the survey told us. And from that AOD lens, there's lots more information that we will be sharing with everybody in due course. I guess I'm interested in any questions specifically about integrated treatment, care and support, or if none about that, any other things that have come out as you've been sitting there listening. Over to you. And just say that if you are looking for more information, the Mental Health Reform Victoria website is continuing to be developed. It's getting better, I guess. I look at it regularly and it is getting better. There is 2 sections on that website to particularly be keep up to date with. One is the engagement opportunities, which lists the opportunities where there's live consultations occurring. Often, as we've seen today, just a heads up, sometimes you get a day, 2 days notice on those consultations. So, you know, it's really difficult. The other thing that we're beginning to see already, which is of real concern, is engagement and consultation fatigue, particularly amongst our lived and living experience members, because there's such a small cohort and everybody wants them to consult. The other other section of that website is around what's happening, so what they have engaged on, and any reports that are delivered will come through that space. The other thing is my email address. If you want to tell me stuff, if you want to reach out, if you want more information about any of those areas, I'm happy to, you know, make connection, really keen to make connection with you all on the ground, and make sure that the service, that I guess the arguments that we're presenting to the department have some real life examples in them as well, as best as we can. We will also be hoping to run future sessions like this if people are interested. So as I said, this is going to be unrolling as time goes on. So there will be more information, more updates that we're able to give people. So we look forward to be able to do that. Thank you for your continued work. Thank you for your commitment and for your interest in this information. Keep your eyes on our VADA e-news for any other updates. Thank you for your participation. And if you have, as I said, reach out, tell us about it. And we'll be pleased to hear from you.